Hey everyone, and welcome to the Balanced Bodies Blueprint. I am your host, Vinny Russo.
And I am your co-host, Dr. Eryn Stansfield.
And we're shifting gears from all the conventional fitness narrative you hear on most fitness podcasts, as our main emphasis lies in preventative healthcare, adopting a holistic approach to nutrition, and challenging the traditional views on various fitness topics.
Our mission with this podcast is to provide you with the information you need to achieve optimal health.
And on today's podcast, Dr. Eryn is going to be leading the discussion here, as we are going to be diving into a hot topic / controversial topic dealing with testosterone in women. So I'm going to just kind of go with the flow here, add my own commentary in there. But Dr. Eryn's going to kind of go into more of the research, if there is any, showing it. The type of physiology that goes along with it, and if there are any potential benefits or if there are side effects with women using it, she's going to be diving deep into all that. So why don't you introduce the topic a little bit here?
All right, so in particular, I'm going to talk about the practice guideline regarding testosterone use, mostly in postmenopausal females, but I think there's been a lot of questions about use in perimenopausal females. So basically females in the 30 to 50 range. So out on social media, I think a lot of people see maybe posts or influencers talking about testosterone use in females. And that's what I want to talk to you about as far as what we know medically. So testosterone therapy in general in females is an evolving area, so that's my disclaimer. There are limited FDA-approved formulations, and there's huge knowledge gaps. So there's a lot of research to be done. So this is a very interesting and evolving area of science. The current guidelines focus primarily on postmenopausal women. So most of the studies looking at testosterone use have been done in postmenopausal women. And most of the guidelines focus on hypoactive sexual desire disorder, HSDD. So if you hear me refer to that, that's what I'm talking about. There is minimal evidence in perimenopausal use. So, the females that are having potentially perimenopausal symptoms, hot flashes, problem sleeping, brain fog, cognition difficulties, that sort of thing. And I think that's the area where most people are taking advantage, if you will, and saying, hey, you should use testosterone for some of these symptoms.
Well, aren't they just kind of saying like this is hormone optimization for women, yet they're sort of disregarding anything that comes to mind with like virilization or blood pressure or even like long-term usage. But I think the whole pitch, because it's a big thing, is how to optimize your hormones. And when you have women that are going through that stage in life, their hormones, for lack of a better term, and I want to emphasize that, are a little bit out of whack, right?
Well, yeah, I think it's a perfect marketing pitch if you're looking at it from a business perspective. What a perfect population to say, hey, guess what? I have a treatment for you that could help your hormones, and maybe it's something that people haven't looked at, i.e. testosterone. Also, it is a scheduled substance. Although that may change with this new administration, they might change the schedule of dosing. And so, it is perfect platform, I guess, for an influencer to be like, hey, if you have these symptoms, if you're experiencing, perimenopausal symptoms, I have a treatment for you that I can give you or that I can sell you. But that being said, medically speaking, there are indications for testosterone therapy. And so I'm going to talk to you about what we know medically as physicians and some of the studies and some of the society guidelines and recommendations instead of what an influencer might tell you. And then you can make an informed decision if, if an influencer feels right to you versus what is actually, clinically indicated. But that being said, the American College of Obstetricians and Gynecologists, so ACOG, states that short-term use of transdermal testosterone can be considered as a treatment option for postmenopausal individuals with sexual interest and arousal disorders. So again, that's that HSDD I was talking about. And that only being done once they've been appropriately counseled about the potential risks and unknown long-term effects. And I think that is really important, as we don't know enough about the long-term effects. So it has been studied, but again, we need more information. In 2019, there was a global consensus position statement endorsed by multiple international societies, including the American Association of Clinical Endocrinology, which recommends testosterone therapy specifically, again, for postmenopausal women with HSDD that would cause personal distress. And that's only after a thorough psychosocial assessment. There is no evidence-based indication for testosterone in premenopausal women or for symptoms such as mood, cognition, bone health, or general well-being. So I think that's really important, right? So all these influencers are kind of trying to market it towards the premenopausal woman, and I can see how that could be appealing, especially if you're having perimenopausal symptoms, mood problems, cognition, like I said, brain fog, problems sleeping, that sort of thing. It might be something that, could appeal to you. Do you want to talk about the data from randomized control studies?
Do I want to talk about the data?
Yeah.
No, I don't want to. That's your job, not mine.
So there's a meta-analysis of randomized control studies showing that transdermal testosterone significantly improves sexual function domains in postmenopausal women. This
Just real quick though, transdermal just means like a topical serum or topical lotion.
Correct.
It's
Yes.
not an injection.
So this is not an injection. That has not been studied. Okay, I want to emphasize that if you're looking at injections at super physiologic ranges of testosterone, that, as far as I know, has not been looked at except for in the transgender population. Okay, so that has not been looked at like in normal female, whether they be postmenopausal or perimenopausal women. So basically, all the randomized control studies looking at this have studied postmenopausal women with HSDD, so this hyposexual disorder, and it does seem to increase their satisfaction of sexual events when they do have transdermal testosterone. A 2019 systematic review and meta-analysis of 36 randomized controlled studies. This comprised 8,400 participants, so a lot of participants, looking at testosterone's efficacy in postmenopausal women. They compared it with placebo. Testosterone significantly did increase the frequency of satisfying sexual events, and this was statistically significant. Beyond that, though, there have been no significant benefits demonstrated for mood, cognition, musculoskeletal health, or, and we had a discussion about this, body composition. Yeah. And so that being said, they are looking at very small doses of transdermal testosterone, so the topical stuff, like the lotion and stuff like that.
Yeah, so my whole thing with that was like when she brought that up, and there was like no increase in muscle mass. I'm sitting there and I'm thinking, listen, if you're gonna throw testosterone into someone, they're gonna increase in muscle mass. And she's like, well, there's really this data here says no, and there's no studies done in women with supraphysiological testosterone being administered to them. And I'm just like, all right, so we have multiple lines of data that we could sort of cross-reference where we have men who have done it and it's been studied and they've increased in lean muscle mass. We've had androgen therapy in women, especially with muscle wasting disease, where they increased in muscle mass. And then we have those transgenders where females crossing over to men have taken testosterone and have increased muscle mass. So with those, we can't give exact like percentages, right? We can't say if a woman takes X amount of testosterone, it's going to give this percentage of muscle mass added to your body. I understand we don't know that, but I do believe, as my hypothesis states, that if women were to take testosterone that brings them above where they normally sit, whether that's between, what's the ranges? The ranges is between 15 and 70 NGs per DL. If it goes above that, then you are going to see an increase in muscle mass. And that's just my hypothesis, and I believe you agree to that to an extent.
So I think, looking at this from a research perspective, so these studies, again, only looked at topical testosterone in postmenopausal women. And I can't talk to you about what kind of resistance training they had in the study, right? So there's a bunch of caveats and potential confounders. So I think the best answer is, if you're looking at lean body mass, the best data available currently would probably be in the transgender population. So transgender men who were born as females who were then given testosterone.
But
But
you saw that there was a decrease in fat mass and an increase in muscle mass, regardless whether they weight trained or not.
well, what I saw was there is an increase in lean body mass. Yes, but again, that was not. We haven't looked at normal females. We haven't compared that to placebo. We haven't looked at age ranges. They have done that study in men, right? We have not done that in
Would a
females.
transgender female be considered a transgender male who was born a female? We're not trying to get into political here or anything like that. This is just how we talk with science. So, born female, you said we don't have that data in normal females. They would be considered normal females who are just getting
Yeah, but we didn't
hormone.
compare it to anything, and to me, that's not an appropriate study. In other words, if you're going to study a drug, it needs to be compared to placebo. And I would suspect that like the same study that they did back in the 90s in males when they were looking at testosterone treatment, where they had 4 different groups, where they actually did resistance training and non-resistance training, and they had placebo and testosterone groups. That is a more appropriately designed study. That's a study that I would love to see in testosterone for women, right? That would be a beautiful study. I don't know that any IRB would actually approve that.
So why don't you explain why that wouldn't be approved? Because I think that leads to the side effects that most women might not even realize. And look, you've got a ton of influencers out there. Well, I don't even want to call them influencers. I want to say that you got these coaches out there that are now starting to push this and saying that low testosterone for women is the issue. And it's a big push. And I even think Dr. Gabrielle Lyons, I think she now pushes testosterone in women. She was big on protein and then having a higher protein diet, which I firmly agree with. But this stance with her with testosterone in women, I don't really agree with. And it's a big thing that's going around. And women who hear this might be like, oh, well, maybe that's all I need to finally see results with my diet and weight training, because I'm tired of looking the same year in and year out without any results, even though I'm putting forth all this effort. So why don't you touch a little bit on the side effects?
Yeah, so there are a number of side effects, and that's why I'm saying the IRB probably wouldn't condone this. Now, again, with this administration, they are changing the scheduling. It might be something that might be easier to study. I'm not a researcher myself. I've done research in the past. But I will say this. The American College of Obstetricians and Gynecologists, ACOG, notes that the most commonly reported adverse events with testosterone therapy in women include hair growth, acne, virilization, so essentially, becoming a small man, which may be irreversible. And also there might be some voice deepening. Some of that is part of that virilization process. But the long-term effects, which I kind of alluded to in the beginning, is what we don't know. And there could be long-term effects with cardiovascular disease and breast cancer risk. These are unknowns. And so I don't think there's going to be very many IRB approval processes for something that might put somebody at long-term risk that we can't even quantify. Oral testosterone is associated with adverse lipid profiles, including reductions in HDL cholesterol and increases in LDL cholesterol. So again, that's hinting at a cardiovascular risk. And oral testosterone is explicitly not recommended. So again, there's lack of long-term safety data, which is risky, emphasizing the need for informed consent and shared decision-making. Again, this is a huge conversation. So if you hear an influencer saying, hey, you should, try testosterone and you're, a perimenopausal female, I would take that with a huge grain of salt. There is an overall increase in weight with testosterone treatment. but no effects were demonstrated again for body composition. Again, this is just with the transdermal, looking at postmenopausal females.
So it's bringing them back to normal,
It's a
not going super physiological.
yes, and it's
or
a
above
very
baseline.
specific, narrow thing. And again, I can't speak to their, the caveats of potentially resistance training as well. Also, I think one of the biggest issues is formulations and dosing, right? So because this isn't really an approved medication for females in the first place, there is a lack of FDA approved testosterone formulations for women, and there's reliance on off-label use of male formulations. So again, looking at a male formulation even for the transdermal stuff and trying to figure out what dose would be appropriate for a patient. And that's even talking about people with HSDD. Transdermal or non-oral formulations are preferred over oral testosterone, again due to the adverse lipid effects. There is evidence for vaginal testosterone in DHEA. A 2022 systemic review found significantly improved vaginal atrophy in multiple domains of sexual function. Again, this is just for sexual function in postmenopausal women. Though doses were highly variable again. And the treatment duration ranged from 1 month to 6 months. Oh, it died?
No, it's dying.
Anyway.
Well, just to cut you off there. So, when you're talking about dosing, so I remember a while back, one of my female clients came to me, and she mentioned how her previous coach told her to take testosterone for a competition that she was doing. Now, me, I was against it, and obviously we didn't do that with our client, but I was like, how did he know what to dose you at? And she was like, oh, well, he told me, men do this, so women should just cut that in half. And I was like, wait. So what about, it didn't go off of your blood work? It didn't go off of any of that and any of your previous history or anything like that? Nothing? No, she was just like, well, if a man is doing 200 per week, a female should do 100. I'm like, that is insane. And no, you should definitely not ever do that again. Like, what are your thoughts on that? Because I think that's how people see it. People see women as a smaller man, for lack of a better term, and they'll just be like, oh, because you're half of a man's size, maybe you should use half a dosage, or maybe 1/3 of a male's dosage.
Well, honestly, this is above my scope of practice. This is not something I would recommend. But if you're looking at I just looked at the transgender studies, and I looked at one, and so these are females that were born females are now transitioning to, I want to be a man, okay? So these potential want to be a male now, they were giving 1,000 milligrams every 12 weeks.
Which is lower than...
That's lower than 100.
Yeah, it's around 80 milligrams a week.
Correct. And these were, I want to be a man. Okay, so just to give you an idea, that is a way smaller dose. Again, I think these doses are experimental, right? I think there's, we don't know is the answer, is we don't know what dose is going to be the correct dose. And that is part of the huge problem. I think also there's testosterone pellet therapy. And we've had clients on that as well. Testosterone pellet therapy has gained popularity due to potentially better bioavailability and more predictable absorption compared to with the intramuscular injection or patches.
Just to let everybody know, they came to us with it already there. We did not do that.
Oh yeah. No way.
No, yeah.
I would never recommend testosterone in a female at this juncture in time. Okay, now science always changes. Maybe there'll be that study that I talked about where they'll actually compare it to placebo and find the benefits there. But right now there is no such study. With pellet therapy, though, critical safety concern, unlike other preparations, it can be easily discontinued. The pellet is not designed to be removed, and it instead dissolves over time, which limits the ability to manage adverse effects or adjust dosing, so it stays in your body. And that could be a major issue. Again, there's no FDA approved testosterone formulations for women in the United States. So the preferred option is a fractionated dose of a regulator approved male formulation. Again, we're using male formulations. This is a huge problem. And the societies do recommend regular monitoring of serum testosterone concentrations. In other words, if for some reason you decide to go on testosterone, hopefully it's for the clinical indication of hyposexual disorder, HSDD. If you do that where it's clinically indicated, hopefully you go to an endocrinologist who is well versed in this kind of therapy, because it is difficult, and they are monitoring your serum testosterone as well. So they are checking on you to make sure that they are not overdosing you as well, so you don't get some of the adverse effects of this. Let's touch on the cognitive, mood, and musculoskeletal effects. So again, we talked about the musculoskeletal effects, so cognition and mood. Right now, there's insufficient evidence to support the use of testosterone to enhance cognitive performance or delay cognitive decline in postmenopausal women. Again, this is the studies usually are looking at postmenopausal women. We haven't looked at perimenopausal women, but there's no good evidence to help with the mood or cognition.
Well, isn't that one of the big pushes, perimenopausal women? And hey, we can make you feel better by increasing your test.
There's no data. There's no data on this particular population. And if you look at the postmenopausal people, that population did not have any benefit. So, if anything, if you're gonna make a conclusion, there's no data.
Well, I mean,
there's no data.
They're probably pushing like, oh, it makes guys feel better and more like a man themselves, and
Right.
puts their mood up. It might do the same for women.
Yeah, so far there hasn't been that data. And there should be regular monitoring to maintain testosterone levels within the female physiologic range. And therapy should be discontinued if there's no benefit seen after 6 months. Compounded and supraphysiologic dose preparations are not recommended due to lack of standardization and safety data. So again, some of the compounded formulations, they vary in the testosterone component. And so again, they can be dangerous, knowing exactly what dosage you're getting, and you're already playing around with male formulations usually. So the current guidelines do not support testosterone therapy in perimenopausal women. Period.
Goes against everything you're hearing on social media, though. Come on.
I know. As the evidence base is derived most exclusively from postmenopausal populations. So yes, you are correct that there is a perimenopausal evidence gap. Yes, this population should be studied. There is insufficient data to make any recommendations regarding the use of testosterone in premenopausal women for treatment of sexual dysfunction or any other outcome. That means any perimenopausal symptoms, cognition, bone decline, cardiovascular benefits, whatever you want to say. There's not enough data there. And I'd also like to say testosterone is one of the several treatment options for sexual dysfunction in postmenopausal women. So there are other options. I think there's actually a new medication that came out recently too. So it's not just testosterone that's like, oh, I have this disorder and now I just need to jump on testosterone. There are other options. Again, that should be discussed with your treating provider. We do need long-term randomized control studies. Like I talked about, it would be wonderful if we could get more studies of testosterone in females. But we need also to evaluate the adverse outcomes, so cardiovascular events, breast cancer risks, and we need development of female-specific testosterone formulations and studies in perimenopausal women.
Well, we're not, and just so you know, like, we're not telling people you don't do this with your body. I mean, you're going to have your body autonomy, and that's fine. What we're trying to do is give a little bit of guidance here, right? You shouldn't really consider it unless you fall into the specific criteria that it has been studied for, and then you need to be using it with someone who oversees you that is qualified to do so and has a proven track record with it. That's really what we're saying. We want you to be safe out there, not listen to these coaches out there that are putting it on social media, and they're pushing male range testosterone dosages in females, and for females that are younger and that just want to do it for vanity reasons, when in reality you start that young, you do it for vanity reasons. Sooner or later you're going to start to hit a point where you're going to abuse it, or you're going to be doing it for too long, and you're going to start getting male-like characteristics that you cannot change back. So you got to be careful out there.
Yeah, and you said something critical, which is we're not trying to tell you not to do it. I'm telling you, don't do it. As from a medical perspective, we don't have good data studying this in other populations. I wish that we did. I wish that I could sit here and say, we've looked at the studies and this is the actual recommendation, but that's not science for you. We don't have that data, so we can't. Right now, the data that we have is in postmenopausal females, and in that specific population, it is only recommended for one clinical indication, and that is for sexual disorder, a hypofunctioning sexual disorder, HSDD. So if you don't have that, you likely will not reap any of these other benefits that an influencer might be telling you about.
So on behalf of Balanced Bodies, we just want to say thank you for joining us on this episode of the Balanced Bodies Blueprint.
We are committed to bringing valuable content. And if you enjoyed today's episode, we'd greatly appreciate it if you can take a moment and like it and leave a 5-star review.
On Apple, just go to the show, scroll down to the bottom and rate it there. If you're on Spotify, go to the show's page, click the 3 dots, and you can rate it there as well.
And if you believe in the power of knowledge, share this episode on your social media to try and get the information out there to as many people as possible.
And as you navigate your own path towards better health, remember that Balanced Bodies is forever in your corner. See you all next week.
The podcast content may include discussions of medical topics and health-related information. However, the information provided should not be considered exhaustive or complete, and it should not be relied upon as a substitute for professional medical advice or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition or treatment.